The value-based purchasing manager at the Healthcare Authority, and in my role I support a lot of our internal programs as we seek to implement and improve and change our value-based purchasing strategies. So that means I work both on the Medicaid program but also with our public and school employee benefits. A little bit about the Healthcare Authority, or just by way of what I want to cover today. I think I have about 15 minutes, so I hope to cover a little bit of background just to kind of set the stage for what we are aiming to do as a Healthcare Authority. And then a little bit about what we've learned and where we are going. So it's going to be real high level, and I think there'll be some discussion afterwards so we can get into some of that. And I expect there will be some pointed questions, so bring them on. So the Healthcare Authority is the largest purchaser of healthcare in the state. Between Medicaid and public and school employee benefits, we cover about 2.5 million individuals. The large majority of those are in Apple Health, but we do cover a significant number of commercially insured lives. So when we think about value-based purchasing, we're thinking about multiple sectors of the healthcare marketplace. And while there are some key differences and some key strategies that we need to tweak or do differently in one side or the other, we do strive for significant alignment across those programs. And we're striving to use our purchasing authority to drive change in the delivery system by rewarding patient-centered high-quality care, by rewarding health plan and health system performance, and drive standardization both across our purchasing programs and contracts, but also what we see in the delivery system setting. So a little bit of background on what VBP is. Some of you may be well versed in this, and this might be boring, but bear with me. So we get overwhelmed with jargon and acronyms, but when we talk about value-based purchasing, or what we call VBP, this is when an employer contracts with a health carrier, like a commercial insurance plan, or for the Healthcare Authority with our managed care organizations in Apple Health, to drive value-based strategies between their organization and their network providers. So when we say value-based purchasing, we're thinking employer. Value-based payments then are the payments that the health plan or health carrier makes to their provider networks. And they must be tied to quality, value of some sort, which we'll get into in a bit. And then value-based care is what happens in the clinical setting. How these payments at the purchasing level, at the value-based payment level, how those translate into care practices and care transformation from the healthcare provider to a patient. So there's kind of different tiers, but it's all based on value, all driving towards the same thing, which is improved patient care, improved experience, and better health. When we talk about VBP, definitions are very important. When a provider wants to know what VBP means, it's not a one-size-fits-all proposition. The right value-based payment arrangement might look different based on your provider type, based on your location, based on your patient size, your patient population. But there are some common factors that are important when we're talking about what value-based purchasing actually is. And to begin with, we've adopted the APM framework, or Alternative Payment Model Framework, from the Healthcare Payment and Learning Action Network, which is a multi-stakeholder national group at the federal level launched by CMS to define what value-based payment models actually are. They've lumped it into 4 different categories, ranging from category 1, which is fee-for-service, all the way to category 4, which are population-based payments. And you can see there's a box of blue outline, which is our Washington State Healthcare Authority's VBP standard. And we set the floor at category 2C. The reason for that is when you look at category 2, this is still a fee-for-service based payment. So provider provides a service, bills it to their health plan, and the health plan pays them a fee. But you begin to have extra elements in that arrangement. So in category 2A, it could be extra payment for implementing a new EHR, or pay for reporting category 2B. It could be, we're interested in your performance on these 10 quality measures, but regardless of whether you improve, decline or stay the same, your payment rate is going to be the same. Just report us your numbers. In category 2C, that's where your performance or the provider's performance starts to impact the amount of incentive payment they earn. That's why we set the floor for our standard at 2C, because it's where you begin to have some portion of the payment tied to performance on quality. And then everywhere above that, from 3A to 4C, you still have that tie of some of those payments in the arrangement tied to quality performance. Now the difference between category 3 and category 2 is you start to take into account the total cost of care. So you're usually setting a cost growth target, and for category 3A, it's an upside only, so if you come in below that, you might share in some of the savings. 3B is where you have upside and downside, so if you come in below, you might get some of the savings. Coming above, you might have to pay some of that back. And then that share of savings, or the amount you have to pay back, can be altered based on quality performance. And then category 4, population-based payments. I won't get into detail, but you have episode-based payments, population-based capitated payments, and then category 4C is a relatively new one. This framework, this version of the framework was released in 2017. We just adopted it last year, and this is one of the main changes, is they pulled out integrated finance and delivery systems. So where the health plan also is the provider. So like your Kaisers is a good example of this. It's a different arrangement. Before, that was all lumped into category 4B, but now it's pulled out as its own unique arrangement type. So when we put targets into our contracts, which I'll get into in a little bit, we're using this blue subset of the framework to qualify as a VBP arrangement. So why is VBP important? And this is kind of set the stage for our journey that began about 2016, is that we want to change the incentive structure. And that means we want to change the motivation we're giving to providers as they care for their patient population. So under a value-based payment arrangement, a provider is paid in some form or fashion for doing high-quality, high-value care for their patients. Whereas in the fee-for-service world, the quality, the evidence, the standardization, the appropriateness of care is not under consideration. If you do the service, you get paid. If it's a poor service, you get paid. If it's a great service, you get paid. And so we want to change that paradigm, change that incentive structure. And when we started this journey in 2016, we started publishing an annual VBP roadmap, which detailed our goals, detailed some of the programs we were working towards implementing, provided some feedback on how things were going and what we were planning to do in the future. And we set a high-level target of achieving 90% of all dollars going through Apple Health, public and school employee benefits into VBP arrangements by the end of 2021. And to get there, we set interim targets along the way. And so this is an aggregate target across our 3 programs. And to do this, we wanted to align our purchasing strategies in a one HCA vision, so that when we are talking about quality measures or VBP strategies, we're doing it in an aligned fashion. And that's important in for a number of reasons. Number one, the Healthcare Authority is a big organization, but a lot of the staff work across the house. So speaking the same language, rowing towards the same goals is really important from an organizational standpoint. Externally, a lot of our providers that serve our patients serve patients across these 3 programs. So you might have a provider who sees Apple Health clients, but is also seeing some of our public and school employees. So it's important that when we're implementing programs that impact their clinical practice, that they're getting a similar signal, regardless of who the health plan is that patient is covered by. So we don't want to say, if you're an Apple Health client, your providers are going to be doing this. And if you're a school employee, your providers are going to be doing this. We want it all pointed in the same direction. And you can see in the bubble, the lighter green bubbles, the actual values, those are the performance across these 3 programs every year through 2019. And so we were exceeding the target, the annual target, in the first 3 years. And then in 2019, we fell short for the first time. And that, you can see that was the biggest jump in the goal from 50 to 75%. And so this is foreshadowing a little bit of our lessons learned. So very round of applause for our managed care organizations. We have yet to have an MCO fall beneath the annual target. Now we're about to assess 2020, so we'll see. But so far, it's been great. On the commercial side, on the public and school employee benefits side, now we're getting into a situation where benefit option choice is impacting some of this score. So our most popular health plan for public and school employee benefits is a free-range PPO, no quality, no VBP, just see whoever you want. It's not the cheapest plan, but it is the most popular plan. And we've been working with our third-party administrator to start implementing some VBP concepts into that program. But to date and through 2019, we were unable to, or had not done that yet. So that's driving a lot of this lag on the commercial side, is just personal choice from our membership. So that's an important thing to note. And we actually worked really hard in the beginning when we launched our ACO benefit option on the public employee benefits side to do a lot of outreach to our members, to promote the benefit plan, to promote value-based purchasing. And at the end of the day, when people are selecting their health plan, it really comes down to two considerations that we've noticed. And that's either someone's really concerned with the premium, they want a low premium and they're going to go towards the lowest premium, or they want the most choice. They want to be able to see any provider that they want, whenever they want. And so we're kind of seeing both ends of the spectrum, but I think that's one of the reasons why that benefit option is the most popular. So a little insight there. Wanted to give a snapshot of what VBP looks like between the healthcare authority and the managed care organizations. So when we're purchasing Apple Health Managed Care, we're not contracting directly with providers. We're setting kind of strategic direction for the managed care plans in their contracting with providers, but we're not directly influencing what those contracts look like. So what we do is we withhold 2% of their monthly capitated rate, and we tie 3/4 of that to quality improvement and 1/4 of that to VBP elements. Now some of this is directed to us by the legislature. That's the right-handed side, the QIS portion. So in a budget proviso a couple years ago, the legislature directed us to change our quality improvement strategy with our managed care organizations. And so now it looks like this. There are 7 measures, and the MCOs must demonstrate improvement on all of those measures or achieve the 75th quartile national benchmark. So it's an either-or proposition. You ask for each measure, you say, did the MCO exceed the national benchmark? If it's a yes, they get a check mark. If it's a no, you go to the next thing. Did they improve over the previous year? If that's a yes, they get a check mark. If it's a no for both of those questions, they get no score for that quality measure. And then you take all 7 quality measures, how many did they either achieve the benchmark or improve? That's your numerator, and then your denominator is the total number of measures. So that's how we calculate the score for the QIS. On the VBP side, we break it into 2 elements. And again, this is 1/4 of that premium withhold. Amounts to 0.5 percentage point of their capitated rate. We want to drive both VBP adoption, which I call the breadth of VBP, and provider incentives, which I call the depth. So breadth and depth. We want to see more dollars going to providers in the form of value-based payment arrangements. So that's the breadth. We want contracts that have VBP elements in them across the board. When I was talking about our targets, this is the percentage I'm talking about, this VBP adoption. But then in order for that to be meaningful, there need to be enough dollars at risk or as an incentive to actually drive changes at the provider level. So that's the provider incentive. How many dollars are flowing to providers directly in the form of an incentive? and that's what that measures. Because we want it to be meaningful. You could have $1 million in a VBP arrangement, you know, for all the services, but then $5 is at risk, and that's not going to do anything. So last year, we were nearing the terminus of that 90% goal, and so we revisited what our vision and strategy was for VBP. Where are we going over the next period of time? And we published our long-term VBP roadmap that outlines some of this long-term vision. And we're not changing significantly. We are still following the HCP land framework for how we define VBP. But, you know, it doesn't make a lot of sense to go above that 90% target. You know, we may or may not hit it, but even if we did hit it, probably doesn't make a lot of sense to go to 95. We're probably not going to, and in fact, it might have a negative impact of forcing providers that otherwise maybe should not be engaging in VBP to go there. Might take away the focus of our managed care plans, of our contracted commercial plans, from doing any of their care transformation work to force them to get that a little bit higher. So we need to change how we're viewing our strategic goals around VBP. Does that mean looking at that framework and saying we want to move more towards the category 3 and above? So we want providers to start understanding total cost of care and things like that. Do we want to start getting more prescriptive and saying we want to implement a primary care model or a maternity bundle, something like that? So a lot of that's still in the works, but these are the things we're thinking about. But we want to maintain our goal of driving quality, curbing the cost trend, and improving access and patient and provider experience. And then a big goal for us is to implement a strategy to address health inequities in our populations and across the state. So we're hoping that we can use our purchasing power to achieve some of that. And we established 7 key priorities for the next period of time. There's a lot of overlap between these, so these aren't all distinct. And there may be opportunities when we focus on primary care, that we can actually impact health equity, social determinants, access, affordability. So there's a lot of overlap if you were to put these in a bubble chart or a Venn diagram. Or a Venn bubble diagram chart. So our 7 priority areas are health equity, social determinants, primary care, alignment, accountability and support, access, and affordability. And let's see, that's my next slide. So there's a lot of work that goes into the background of this. Everybody wants to reduce inequities. Everybody wants to improve our focus on social determinants. But what we've learned in the last year or so as we've worked on our internal strategy towards these things is every step you take opens up a huge box of questions and uncertainties. So we're trying to be very deliberate about this. We know that there's risks in unintended consequences if we move too fast or if we kind of jump too soon. So we're starting by evaluating what opportunities are there to just start looking at our quality measures in a more detailed fashion. What kind of demographic data can we parse out those quality measures by to see how our populations are experiencing healthcare and what their health outcomes are based on either where they live or any other demographic markers. And then what are our opportunities through the Medicaid transformation to drive social determinants? We have a multi-year project on our multi-payer primary care initiative. So when we talk about what's coming next, and I'll try to wrap in the next minute, whole person primary care is one of our big focuses. Advancing health equity, social determinants. These are kind of the 3 that have risen to the top in terms of where do we want to put most of our effort and resources. And we do believe that by effectively addressing those things, we can do a lot to improve access, affordability, but also align across our business, align across the marketplace in Washington State, both commercial, Medicaid, and Medicare, and provide some accountability and support to our partners. So when we think about the next iteration of the Medicaid transformation, when we look to the renewal period, We want to be more intentional about roles. That means engaging ACHs, community-based organizations, providers in ways that best suit their strengths. And I think that's another lesson learned that I'll probably share in the panel discussion, that we can do a better job of emphasizing the appropriate role for all the stakeholders involved and all the partners, and that we can send clearer messages about what our expectations are in this journey. And that's going to be really important, especially as we think about health equity and social determinants. So I wish I had more detail to share about what's next. A lot of that is still in development. We're still working on the Medicaid transformation renewal application for the 1115 waiver. So not a lot of concrete details to share, but that is the direction that we're moving. So that's all the slides I have. When this is shared, there's an appendix with some other informational slides that you might find interesting or you might find extremely boring. So.